Thank you. I want to thank Dr. Ahmed for having me here. It is a real pleasure. I'm a psychiatrist, and basically what I'm going to do today is try to envision insomnia and other sleep-related disorders through the eyes of the psychiatrist. And that way, once you get your patients that have mental illness, in whatever specialties that they're coming in, you can be aware of certain cues and that can practically worsen their pathology and know when treatment is necessary immediately, when something needs to be done, or when the patient needs to be referred to the specialist. So there it is. Complications and management of sleep-related disorders in patients with psychiatric disorders. Disclaimer, all I'm trying to do is to give you a better perspective of what I know for you to try to emerit it and put it into your practice. No way I'm trying to, try to change your clinical judgment. It's just, for you to have an extra tool, a different perspective to help out in your treatment with your patients. Okay, so our objectives today is to understand the sleep quality in the context of a psychiatric management. Also, we're going to recognize particular sleep patterns and how certain pathologies, psychopathologies, have different form or pathognomonic changes which are typical to those disorders, and how to address them promptly in order to prevent any type of relapse or worsening of the course of the illnesses. Okay, so almost all psychiatric disorders, have sleep disturbances, okay? At one point or another, or are embedded in the pathology by itself. There is a bidirectional causation. We don't know what came first, chicken or the egg kind of thing. Why? Because it's been known that a lot of individuals who have mental illness present early with certain sleep disturbances, and then later on the pathology develops. Some of them have the pathology and start presenting with different types of sleep disturbances. And by itself, having sleep disturbances, particularly insomnia, by itself in any healthy mental individual will predispose to developing a mental disorder. We have, through the years, sleep has been studied extensively. And even though nowadays we have a lot of methods that we have used, a lot of advances, I have recognized a lot of aspects of sleep, there is still a lot unknown of what really happens through sleep, okay? And especially in this type of population, the mentally ill. But we do know enough that there is a need for direct treatment of the insomnia, irrespectively of the mental disorder, okay? Why? Because, again, that would prevent relapse and help the course of the treatment of the patient, okay? So overview of topics that we will cover today. We will do sleep in patients with psychiatric disorders, how the sleep in these patients are. There's sometimes pathognomonic changes to some pathologies and other changes that are just associated in others. The risk of, that we'll have on the psychiatric patient due to sleep disturbances, and the impact that sleep disturbances have on the course and treatment of the condition. The effects of psychotropic medications on sleep, and how we can use them and what we have available, and the impact of sleep deprivation on mental health. Okay, so basically, in the past, when we, started studying sleep, we thought that, it was just a passive process, okay? At one point, we even thought that, putting a patient not to sleep can, help in certain disorders. And, that was until 1953 when we discovered non-REM and REM sleep. At that point, we had better methods to study sleep, like hypnotrophic methods and EEGs. And from there on, we started studying the sleep cycle. And we learned very much that sleep is a very, very active process per se. It's fundamental to brain function and a central role for mental health. Why? Because when we sleep and we have a regular cycle, basically, what it does is, in the brain, it helps with our cognitive process. It helps with our emotions because it helps consolidate what we learned through the day. We'll see later on that sometimes when we don't have a regular cycle through the night, certain pathologies tend to, for the individual to consolidate negative memories. That can happen also with some medication. At the same time, the healing process due to stressors that we went through the day are not able to be processed, and then we will continue on with an emotional state, more anxiety, more liable, and reactive to certain situations, as we don't have a clear mind to function, and at the same time not able to process. In the same way, somewhat like somebody's learning to play an organ. Sometimes you're playing a guitar and you're having a hard time, knowing how to put your fingers on it, and you ended up frustrated. You go to sleep, and for some reason you wake up the next morning and bam, you pick up the guitar and you start playing the notes. Why? Because those memories of what you were trying to do got consolidated, and it helps your body and your brain to be able to execute certain things. Okay, and it's sort of like something, like an anecdote in that way. And also that helps with management of interpersonal conflicts with other individuals and yourself, to be able, to be stable as a person. Also, personality disorders get affected with these things. Okay. Well, it's a little a funny little thing there. Insomnia is very common. Try not to sleep over it, but it's a very important thing. 30 to 60% of people with mental disorders come to your office and complain of insomnia. Here's a diagram that better shows that. What it's trying to show there is that individuals that come to the office, whether it's the psychiatrist, relatives, especially the primary care physician, and they have some type of sleep disturbance factors or pathologies per se. The main one, precipitating insomnia is mental disorder. About 30 to 40% of all the others, periodic like movement, sleep-related breathing disorders, the mentally ill patient will be the main one, the largest group who will be complaining of insomnia, about 1/3 of your patient population. Okay. Now we're going to start with the first topic, which is sleep in patients with psychiatric disorders. Here I want to mention several of the most common and also the most debilitating mental illnesses, and how sleep relates to these disorders. Let's start off with major depressive disorder. In major depressive disorder, the patient will complain, of insomnia or hypersomnia, being that said is one of the diagnostic criteria, sleep disturbances. And practically, I'll go over a little bit more on the other slide on this, but there is pathognomonic changes seen in the sleep cycle of a patient with major depressive disorder. Has been identified. It can be identified as a prodrome before the patient develops the disorder, before the patient is exacerbated into the disorder, has already suffered from major depression. And, you see things like taking a long time to fall asleep, increased sleep latency. You'll see fragmented sleep, increased wakefulness throughout the night. That's what it means. And nightmares, they might complain about nightmares as well, and so on, which that, due to that disturbance in the cycle, sleep will not be efficient. Therefore, the patient is sleepy the next day, and it's a constant cycle where emotions cannot be controlled and basically worsening the symptoms. About 80%, 90% of adults and 90% of a child with MDD experience sleep disturbances. So, more than an 80%. It's a very high rate. Being that said, sometimes you have a patient, there's been a lot of studies that a patient is not given an antidepressant per se, and you put the patient to sleep, with a hypnotic or whatever not, and as the patient starts to sleep somewhat, that sleep cycle starts to catch up and regulate somewhat, and the depressive symptoms improve just with sleeping by itself, which is a mode of treatment that, we use, okay? And I'll explain why, because basically if a patient is not treated for the insomnia and only for the depression, what happens? You treat the depression and the patient stays with residual insomnia symptoms. What happens after that? We have noticed throughout a lot of studies that later on the patient has a much higher rate, about 50% of having a relapse, okay? Just because the insomnia is there, persistent after that. So the goal is to, give an antidepressant to the patient, cognitive therapy, of course, and all the things that we do. But at the same time, it is very important to put the patient to sleep, okay? At least in the short term, as the depression starts to resolve, okay? Why? Because there's changes in their sleep cycle. For example, they're going to have a reduced total sleep time. The latency for sleep is going to be increased, so this patient take a long time in bed to fall asleep. Once they fall asleep, they have a reduced rate latency, so they go automatically practically into REM, okay? What that's saying is that, for example, the first half of the night, the patient spends the more time, and a regular person spends most of his time on slow wave sleep, okay, non-REM sleep, okay? And as the night progresses, okay, see, it's working. Okay, as the night progresses, that gets a bit shortened, and REM starts to increase. The period of REM increases. Okay, so the REM is shorter, and then it starts to increase. It takes about an hour and a half for a normal individual, 90 minutes to hit the first REM, and so on throughout the night. And then REM periods start to become longer, and the deep sleep start to get shorter. In a depressed individual, they're going to spend more time in REM, but they're going to spend more time in REM, in that first period, half of the night. Why? Because they have, total amount of time is decreased of sleep about 5 hours, morning awakenings, and at the same time they're taking long to go to sleep, okay? That's even becomes shorter. Being said, they also have frequent awakenings, fragmentations of sleep, and not having a normal cycle. So they're spending more time in REM, even though, it's going to be less REM periods throughout the night. They do spend more at the beginning. In fact, the first period of the night, when they go straight into REM, practically, it's a bit longer than the diagram doesn't show it that well, but it's longer than on a regular individual. And psychotropic medications like antidepressants, especially SSRIs, tend to shortened REM. So that's already contributing to the treatment, not just the depressive symptoms itself. Putting the patient to sleep then helps that cycle to try to catch up and try to resolve the episode, okay? Okay. So I'll decrease sleep efficiency at the end, which is what's going to happen, what I just explained. Okay, so let's talk about the bipolar disorder patient. The bipolar disorder patient basically has a lot of these pathognomonic changes similar to a major depressive disorder individual. For a manic episode, one of the criteria is decreased need for sleep. About 69 to 99% of patients report difficulty falling asleep or staying asleep, and that's independent of just the manic episode. That's the patient per se, even in a stable state. Some report hypersomnia. That's if they're in a depressive episode. Sometimes it's sort of like a prodrome, cueing that the patient can be about to decompensate or become depressed. And the same goes when the patient is complaining of insomnia. Their insomnia is severe, worse the course of illness, and where it says most common prodrome of a manic episode, it's something that I want to make you aware of. Why? If a patient comes to your office, it's your bipolar patient, doesn't have an appointment to see their psychiatrist in several weeks, and for some reason, you have, it's your patient, you have a very good rapport with them, and the patient comes and says, doc, I've been having difficulty sleeping for a few nights now. That's like an emergency stat order, fast. Get to the bottom of it, try to see what's happening, put something on board if they cannot get to the psychiatrist, or try to read the psychiatrist, because that's a biomarker for relapse. That's been studied, and it's a biomarker for relapse. Once they have a period they've been sleeping very well, and they start saying, doc, for some reason, even though you don't see them manic yet or even hypomanic, then they're talking to you normal, and they're saying, it's been a couple of nights that I haven't slept well. That's what's going to happen if it's not addressed, okay? And, you'll see me saying these things throughout the presentation, and the reason is because there's a lot of biases with psychotropic, with sedatives and medications used for insomnia and whatnot. And, I want to make a point clear. We'll get to the end where sometimes these are very important to use. Okay. The circadian system model. This is a great model. This is something that I use myself in my practice with my patients. It's not, it's a tool. It's a tool for us to use, a great tool. We need to use medications along with this, but it's sort of like we're talking about you're depressed or you have an adjustment disorder or whatnot, and we refer to a psychotherapist and they do their part and we use the medication. And this, I've had very good results when a patient sticks to this type of model. It is very hard for them to stick to this type of model because, there are individuals who per se are prone to engaging in, behaviors that cause, a lot of pleasure, inappropriate behavior, things like staying up at night, going out, not eating right, and that it's very hard for them to do. But when they stick to it and they have a lot of support, family members that help them stick to it, they basically do very well with medication treatment, right? And basically, what this says is that we have studied that individuals with bipolar disorder have a disrupted or suboptimal, a circadian rhythm. Okay, their internal clock is not calibrated the way that regular individuals have. Okay, so if you get these individuals and you tell them, listen, I don't want you going to sleep past 10:30. I need you to not wake up at 11, wake up 7, 8 o'clock in the morning. Okay? I want you to eat at regular hours. I don't want you eating late at night. Do exercise early in the day or early in the evening, not late in the evening. All these things that would make us at any point or not, get a little bit of insomnia or anxiety, whatever not, with them is detrimental. Just a little thing will throw them off. And if they maintain this cycle, basically, they will do well. Okay? It's also used as a biomarker when these things are not being done the way they should. Like I have a patient, he likes to drink coffee, and I keep telling him, not past 11 or 1, I use the 1. And every time he comes back and gets decompensated because he likes to smoke late at night and drink coffee. Throws him off immediately. Let me see if here, okay. Here we, in the circadian model, has been studied many genes. These are some of many and many that are being studied in relation to the circadian rhythm. We have the clock gene, the timeless gene, the RNT2, and the DBP gene. Particularly in mice, they have studied the clock gene, which is the deletion of exon 19. And what it's shown is that when this gene is altered, these mice engage in manner-like behaviors, high reward seeking behaviors, if sleep, they're like, they're a bipolar patient, for real. Other things that studies like certain proteins, so the gene products, which this one, Reb alpha protein, it's in relation with keeping that homeostatic regulation of the circadian rhythm. And it contributes with mood regulations per se. When it's disrupted, lacking, it causes a lot of disturbances due to the fact that it's not regulating well that circadian rhythm for you to regulate your mood symptomatology. And interestingly enough, the best medication used for bipolar disorder, which is lithium. Okay, we have tons of medications. Some people cannot tolerate lithium. It has a lot of side effect profile in the long term, but it's by far the best medication to treat bipolar disorder. It has been shown that it correlates with normalizing that circadian rhythm. Now let's go into anxiety. Everybody suffers from anxiety, right? And we see a lot of patients coming to your office complaining of anxiety. Sometimes, unless it's something really disturbing per se, the generalized anxiety disorder that, or social anxiety disorder, panic disorder gets to agoraphobia, which already go, let's go to the psychiatrist because this individual's not even leaving their house. You have a lot of patients coming in complaining of anxiety. And we have found some changes in the sleep of these individuals, and they'll complain of it. They'll give you the symptoms. But, in contrast with the last two pathologies we were talking about, these are not, this is associated. It's not a pathognomonic per se seen, in a sleep cycle study. But you will see that the person takes long to fall asleep, and above all, having frequent awakenings throughout the night. Okay, and like all these, of course, the time spent in actual sleep is going to be less, even though sometimes this individual spend more time in bed, but the quantity of sleep is decreased. Like I said, there are not real alterations into it. But we see decreased percentage of the night spent in slow wave sleep with this deep sleep, and increased percentage of the night stage 1 compared to controls. What does that say? The patient is like a patient that's using a benzodiazepine. Spends a majority of the first time of the night on stage 2. See? And 1, because it's jumping back to an arousable state, getting awake again, getting awake again. So what happens? They're not getting a restorative sleep, and they're not getting through having a proper REM. I mean, even though if we cannot show it, we can speculate that that's what's happening. Post-traumatic stress disorder, big time. We see this on practically any individual that has a trauma, witness a trauma, especially, with a loved one, even a loved one who have witnessed a trauma and speaks to frequently to their son or daughter constantly about the trauma they suffer in the war, it can even precipitate this disease, okay? Not necessarily you can see it on an individual that comes to the office and says, hey, I just came back from Afghanistan. Can be somebody that got assaulted, whatever not, okay? They basically complain mostly of distressing dreams and difficulty falling asleep. Like all the anxiety disorder, they're going to have a lot of fragmented sleep, a lot of arousal during the night. And one thing particular to that we have studied is the WASL, wake after sleep onset. This is important then because 2 things. You can measure directly using this method how much really wake time was there after the patient falling asleep, okay? How many fragmentations of sleep, going back to stage 1, the patient had. This is important for PTSD because we have noticed that the patient that has PTSD, the more they have, the higher the WASL, the more severe and more frequent are the nightmares, okay? The more they fragment and spend, not on sleep time, once they go back to sleep, it's when the nightmares are going to be very vivid, severe and distressing, and they're going to last longer. We don't have specifics like the other diseases of seeing it, on a scale, but it can be telling us that these individuals are practically sort of like an MDD, going straight into REM, and it's lasting long, trying to catch up, particularly probably by the end of the night. And they're going to have increased REM density, sort of like also like major depressive disorder, which is that the frequency of the REM, rapid eye movement during the REM sleep are going to be higher, are going to be faster. That's telling you this individual, even though we need to, hormones are active during REM, and we need this for restorative sleep, okay? It's super overactive and dysregulated, and most likely a lot of hormones that have to do with stress are being more active than the ones that don't. So memory consolidation gets impaired as well, and negative memories get consolidated, and it's a vicious cycle. The big one, schizophrenia. Okay. When you have your schizophrenic patient, be aware, because the prevalence of sleep disorder, especially insomnia, is 80% or higher, and it's very severe. But what happens? The schizophrenic is like a dementia precoce patient. That's what it used to be called. The executive function is poor. Sometimes you're asking questions, and a lot of what we do as psychiatrists is through the years, through the 4 years, is trying to learn how to speak to these individuals, how to engage with them, how to get information from them, because it's difficult. And it's not because they're angry and paranoid, that can happen, very angry, try to attack you and paranoid. But most of the time it happens because these individuals have such a poor executive functioning that it becomes hard for them to disclose what they're feeling, right? So they seldom, complain of these symptoms, because you start talking to them, how you doing? And we're looking at that psychosis, we're worried about the psychosis, we're worried about this individual hurting someone else, or, being able to function and stay in their assisted living facility, or behaving well with the parents, that we sometimes miss asking, even around sometimes as psychiatrists, are you sleeping well? Sometimes psychiatrists, even this becomes so challenging that they tell you, oh, even if they tell you, we're not sleeping well, we're like, okay, what else are we going to do? Look how much antipsychotics, look how much sedatives they have. What are we going to do? So it's, that's normal baseline. Well, is it? The truth is that, they have a lot of sleeplessness. And that's being at baseline. These individuals have a problem sleeping. They are like a delirium patient. Their sleep cycle is turned upside down. They tend to want to sleep during the day and not during the night. That becomes challenges also for caregivers, okay? And it can, at the same time, distort them, because our human brains are made to sleep during the night and not during the day. That predisposes when they're not sleeping to exacerbations, okay? And at the same time, like other pathologies, it precedes relapse and decompensation. So again, if they come like that bipolar patient and tell you, I'm not sleeping well, sometimes we say, oh, no, that patient's just saying it. Try to look into it because that will lead to an exacerbation of their illnesses, okay? Worsening course of their illnesses, worsening course of maintaining a baseline. And these are the type of individuals that you want, and also bipolar, but you will want to consider long-term or indefinite treatment with a sedative or hypnotic for sleep. Okay, so this is a nice diagram because, you see how totally different in comparison to normal subjects and the major depressive individual, how distorted the sleep is on a patient with, schizophrenia, okay? So, for example, you have the WASL that we were talking before. It's increased in major depression, but look at the, this thing's not working, sorry. Look at where it says WASL, look at how high, there it is, I got it, thank you. Okay, so look how high on a schizophrenic patient is. It's somewhat high on a major depressive patient, and look how it is on a regular patient, it's low, okay? That latency of REM on a patient with schizophrenia is going to be high. So, basically they're going to take long to go into REM, normal on a regular patient. And like we discussed before, on a depressed patient, it's going to be low because they're going to go right into REM. Slow wave sleep, it's going to be high on a patient with depression and very low with them. So, what we're saying, the whole cycle, there's no real compensation there from one thing to the other. It's going all over the place, okay? Like right here, they spend a lot of time in non-REM, like a PTSD patient, they're in stage 2 there, and look how low in major depression, and vice versa here in REM 1 sleep, very low time to hit the first REM. This index here, basically what it says is this is a ratio between the REM 1 and non-REM sleep, okay? And it can give you certain things. Basically, what it says is that, the index of endogenous periodicity has been shown on some studies that basically an individual who has a low ratio means that the REM, they're going to be spending very little time in REM, and that tells you this patient is about to have an acute exacerbation, okay, versus a ratio being high, it's more on the slow wave sleep. And I'll show you a little relevance here in the next slide. Okay, so, these are changes that we're going to see. If the patient's having positive symptoms, like I said, shorter REM latency, longer sleep onset, here, and, more prominent negative symptoms, you're going to see shorter REM onset latency. They're going to, go straight into REM. But this is very important because a lot of people are studying this. Why? Because when a lot of time of the night on a schizophrenic patient is being spent on REM for some particular reason, they, like I said, it can change throughout how the pathology is presenting, acute exacerbation, continuous schizophrenia disorder. The more time in REM and the greater REM density, right, it's a biomarker for suicidal ideations in these individuals. They have a greater percentage of possibly committing suicide. And, people are trying to look for these, for schizophrenics who are not the population that more frequently commit suicide, but when they attempt it, they, a lot of times they could succeed. And, that's why it's admirable to look at these things. Psychosis, well, what we're trying to see here is any pathology that involves having a psychotic episode. 80% of subjects have at least one sleep disorder, okay? And insomnia 50% of the time, okay? So psychosis has a high comorbidity with sleep disorders. Some studies show that 3.3 per subject, sleep disorders per subject being, restless leg syndrome, insomnia, nightmares, basically, are comorbid with a precipitation of a psychotic episode, okay? 52% are severe, about 50% is insomnia, 48% is nightmares, the ones that have a psychotic episode, and it correlates with the severity of the psychopathology. The more severe the insomnia, the more sleep disorders they have, the more severe the psychosis you're going to see in the pathology. These individuals have a lower quality of life, health issues are going to deteriorate. I don't know, some of you go to nursing homes, so you see that the schizophrenic who's 50-something years old looks about 80 and is suffering from multiple metabolic issues, okay? Strokes, diabetes, congestive heart failure, whatnot, okay? And over half discussed with the medical professional. Okay, so out of 57%, this, we've been noticing, and this is important to the presentation, because about 57% of those patients with psychosis that discuss with a healthcare professional that they're having insomnia, only 30% were treated, and out of those 30%, they were suboptimally treated. That caused more severe paranoia, hallucination, more disorganized symptoms, in relation with the sleep disorder. Like I just mentioned before, these individuals, physical health is going to deteriorate as well, and quality of life as well. And there's no difference in antipsychotic dose between subjects with or without insomnia. But as I say, it says that even if you treat the psychosis, you have to treat the insomnia. Sometimes there's a patient that comes into my unit, and the patient is even sometimes naive of benzodiazepines. And the resident, working with me, looks at me like, why, doc? What are you putting a benzo? Why are you doing that on a... Well, there's other reasons why I do it. There's certain benzos that would just decrease the psychotic episode per se by calming down, decreasing cortisol, why not? But at the same time, also in a bipolar patient, if you put them to sleep, okay, the episode will resolve faster and have a better prognosis. Okay? That doesn't mean that I will keep the patient on benzo long term. Okay? Depends. But at least the first few days of the admission, it's something to look at, depending on the presentation. Okay. So now we're going to talk about the risk of psychiatric disorders and sleep disturbances. So the same thing, chicken and the egg. There's an increased risk of developing psychiatric conditions on individuals who have poor sleep, okay? 4 times higher of developing a major depressive episode, double the risk of an anxiety episode, of getting an anxiety disorder. It worsens the mental disorder of the patient if they already have one. They decompensate. Here on people who have night shift, there's been some studies that there is a high risk, about 46% of individuals who work nights have a higher, more than 5 times per week, 5 nights, have a higher risk of developing a mental disorder. And if they come with a concern of sleep, anyways, because they want to sleep during the day, it should be addressed. Okay, we see this a lot on the nurses and on us ourselves. Security guards, policemen, things like that. And treating the insomnia will help with the psychiatric disorder if the patient already has one. Okay. Having poor sleep, insomnia, it has been embedded in one of the 10 warning signs of suicide, okay? So, a patient is coming with feelings of worthlessness, giving all his subjects his car, his brand new Mustang to his friend or whatever. Now, why the guy's doing that? And it's also telling you, hey, I'm not sleeping at all. I have been sleeping 3 hours a night for the past 3 weeks. Well, run, because it's one of the risks of the patient, possibly thinking about suicide. A 4-fold higher incidence, okay? And that's independent of any social demographic or concomitant mental disorder. So it can happen to anyone, rich, poor, healthy, mental or mental illness. And it's a risk factor to complete the suicide. The good news is that it's amenable to treatment. We identify it, we treat, and the patient improves, can recollect their thoughts, and possibly not commit the suicide. 32 studies that we have checked, 10 of them in children and adolescents, and 22 in younger, older adults throughout multiple countries have linked sleep disturbances with suicide. Okay. So putting the patient to sleep will improve, we said before, the psychiatric conditions, the outcomes, risk of relapse, the residual insomnia that we talked about is basically just the same thing with major depressive disorder relapse. So we must address the sleep disturbances. And 62% of remission rate compared to 3%, 102% alone. What I explained at the beginning, okay? That that residual insomnia can cause a relapse and have longer course for the patient to resolve their depressive symptoms and to have a higher quality of life. Okay. Basically the same thing, not a pathognomonic, but, remission rates are worse if sleep is not addressed on anxiety patient, predisposing to psychiatric pathology. Basically it's the same thing on this slide. We'll go to a better slide that we have just discussed, just a little recap there. Okay. Before we go to the next topic, I want to talk about management of, briefly, I don't know how much time we'll, briefly about the, management of sleep disturbances. You treat the psychiatric patient, the schizophrenic, the bipolar, whatnot, just like a regular patient that just comes for primary insomnia, okay, or secondary, okay, which is what? Lifestyle changes, okay, not eating, not doing drugs, drinking too much caffeine, no alcohol, nicotine, blah, blah, blah. Behavioral strategies, sleep hygienes, telling them not to watch, TV late at night, you just use the bedroom for sleep, exercise, relaxation techniques, the whole works. mindfulness, and psychotherapy, which is very effective, okay? Cognitive behavioral therapy, because at the long run, when you use cognitive behavioral therapy, basically we have shown that in conjunction with medication, at the long run, the patient has less chance of relapse versus with medication alone, okay? And medication management. Hypnotics, let's go briefly. These are the FDA-approved ones, okay? Basically, what do we use temazepam? All of the time. We all use it. Why? Because it's the one that doesn't affect the liver, less. The rest of them affect the liver extensively. A lot of interaction with the rest of the medications. These patients are using multiple medications. They have a longer half-life except for triazolam, but triazolam has, its other issues. It has a high risk of withdrawals. Even if you use it for a very short period of time, you have to start titrating it down slowly. So it can be a problem in a patient, especially a psych patient who it's not someone so highly functional to use. So we basically, why sometimes we stick to temazepam. It has a shorter half-life, and it doesn't interact much with medication. Here are the C drugs. We have the zolpidem and the zolpidem ER and other type of forms, for sleep induction, for maintenance, Lunesta for sleep induction and maintenance. And these are good at times, but it has a lot of risks, like, doing activities like you were awake, like driving, cooking, and so on, not by being asleep, especially in the elderly, risk of falls, like these have as well. So, these are things that we must look at when we use this type of medications, but they are effective. Other medications that we do use off-labels are a lot of antidepressants and some antipsychotics, like trazodone, very often used because it's very benign, but sometimes it doesn't address the issue, and it can cause other problems, like it prolongs REM sleep and can make nightmares worse, a risk of falls, orthostatic hypotension with the Seroquel. It's amazingly or not, it's pretty good in regulating sleep. It doesn't affect the cycle so much, but then it's an antipsychotic and it will have a lot of other detrimental side effects to the patient. Mirtazapine, very good as well, but again, long half-life and can have all the detrimental effects. And amitriptyline, old school doxepin can be good in some patients, especially alcoholics. And basically what we're using there is the alpha-1 and the antihistaminic effect. Other antihistamines and anticholinergic, which is something that we want to avoid. Also, these medications, some of them like these don't have too much anticholinergic. Trazodone doesn't hardly at all. But Benadryl and doxylamine, which we can buy over the counter, has a lot of anticholinergic properties in the elderly. Cognition. We worry about the benzos. But the first medication study to cause impaired memory and dementia, it's the anticholinergics, and it makes sense. What's lacking on an Alzheimer's patient. And these are over-the-counter, herbal supplements that we use sometimes to treat. Some of them are pretty safe. Some of them can cause a lot of side effects, liver problems. Valerian has more interaction with medication than if you use a benzodiazepine, and people think it's pretty safe. This is hops, whatever, not chamomile. I've seen a linden tea, which is very safe. A lot of Latin people use it to sleep, and it's even healthy. It has an oil that's good for your heart and whatever not, but it increases a lot of medication, especially the anti-epileptic ones and sedatives. And I've seen patients look like in a comatose state, and it's because they're drinking that safe thing with medications. Okay, so basically, the risk of these medications is that it also disrupts the sleep cycle. And it can precipitate disorders like periodic movement disorder and restless leg syndrome, okay? Like the antipsychotics, the amitriptyline, itself, and all of that, decreasing the antipsychotic, decreasing the dopamine, and it's going to make them worse. So you might not address the sleep quality of the patient, and at the same time, make the patient worse, or precipitate insomnia, right? And some medications like melatonin and Rometium, which is a melatonin receptor agonist, can cause worsened depression, headache, even next morning sedation, which it says that it doesn't, worse than others. And compared to placebo, it has been shown in getting feedback from patients that it's not as effective as it was thought to be. Okay, and fast medications that can cause sleep disturbances, basically the same ones that we use to treat depressions and psychosis and bipolar, the same ones that we use to try to treat insomnia. Look at clonidine. Well, there's causes insomnia, but at the same time, we use it for sleeping individuals with ADHD, okay? And sometimes individuals with PTSD, with processing. So basically, the same medications that we use that we're thinking are inducing sleep can precipitate insomnia. More of a little diagram here, the same thing I've been saying with the alpha-1 receptor, 5-HT1 receptors, they all going to affect, at some point, the sleep cycle, and basically maybe not address what we're trying to address on the patient. So we have to look for options, try to look for different strategies, adjunct treatments, because for these individuals, having quality of sleep is very difficult. And, certain neurotransmitters, are important in regulating the sleep cycle and sleep itself, working together to produce melatonin and whatnot. Okay. Same thing I've been saying. Another thing that we see the schizophrenic, whatever, we hit them with a lot of medications at night, and then throughout the day, the patient does not fall asleep, but it's very somnolent, not being able to interact in group if it's going to some type of fellowship house or PHP program. Their quality of life is decreased because, not able to at least enjoy a bit with, socialize with others, and they build tolerance fast. Okay, you start Seroquel and you give somebody 25 milligrams of 12.5 and they'll sleep for 14 hours. By 2 weeks, you got the bipolar patient on 400 milligrams twice a day and they're having a blast. Like that, fast in some individuals. Okay, the tolerance to not to the effect of the antipsychotic, to the effect of the antihistaminic for sleep. Okay? And, like I mentioned before, might precipitate, disorders like paralytic movement disorders, restless leg syndromes, and whatnot. These are adverse effects of some substances, okay? Again, it's basically the same thing. Alcohol, caffeine, nicotine, are going to be affecting the way we sleep, beta blockers. Patient with congestive heart failure needs a beta blocker. It's important, and the other medications, but, I'll give you a little hint. They need it, we keep it, and then when us, like me, a psychiatrist, goes to a nursing home, we have patients on multiple medications they can now do without, because then, they'll die of their arrhythmias, congestive heart failure, but the majority of these medications disturb the sleep cycle. Beta blockers are sedating. Some people might take it for social anxiety, but guess what? They decrease the amount of melatonin an individual makes. So sometimes the individual takes the beta blocker at night to relax, or takes it because of his medication. It's easy, falls asleep. Medication has a short half-life, like a propranolol. Wakes up at 3-4 o'clock in the morning when cortisol is beginning to rise. They have a suboptimal melatonin at that time, boof, and those patients having a panic attack at the middle of the night. Calcium channel blockers, basically, like I mentioned, risk for depression, delirium. Basically, what you have to look, and especially in the elderly population, sometimes when I get them on the floor, I take a lot of it out and then start putting, at least what's necessary. I don't have a hypertensive episode or anything like that, or heart attack, but start putting them back little by little and then working with the primary care that's on board with me, because what I want you to take home, the majority of them can cause a psychotic outbreak, some of them depression, a lot of them manic episode, like the steroids, the beta blockers, or not, and all of them will cause a delirium. So you have the elderly patient who gets a UTI, which causes a delirium per se, or psychosis, and it's a multiple of these. Wow, takes a hard time to get that patient out of the delirium on the floor. And at the end, we have to adjust and put them back because they need it. So, but it's something to look at and try to address, okay? You know. And sleep. So the impact of sleep deprivation in psychotic disorder, basically what I've been saying, sleep deprivation and mental health. Profound sleep debt is another thing. It's related with the problem with ranging from attention lapses, reduced short-term memory capacity, impaired judgment, microsleep, sleeping throughout the day several times, mood disturbance, paranoia, and hallucinations. So this is just a measurement of an individual that, you know, maybe all of us have had this when, you know, going to medical school, even now, sometimes I work a lot, is that we start sleeping 4 or 5 hours a night and we are having a debt with that sleep, okay? And that starts to accumulate, and that not only emotional, which can happen and can precipitate mental illness, also detrimental to our health. This is what insomnia, you all know, okay, leads to, okay? Diabetes, starts destroying your pancreas, heart problems, okay? Variations on your heart rate, you know, can precipitate arrhythmias, or you have an aging heart, the heart of an 80-year-old when you're 40, okay? And impaired judgments and stuff like that, which might impair the way we function with others, might impair the way we react to others, get into conflicts, you know, accidents, whatever not. And basically here I'm saying the same. Look, like here's a little thing that there is a 10% increase in motor vehicle accident following switching to daytime savings, okay? You know, people react worst on situations, you know, not in alertness, and also because of consolidation of certain emotions, whatever not, in their sleep, okay? I think I already kind of mentioned this. Yeah, basically the same thing that I was mentioning before. Here, what we're looking at is basically in here is that some studies have shown that if you get an individual, it happens to anyone, because I've been, you know, once I remember I was in college and pre-med, and I went almost 5 days without sleeping, believe it or not, to pass all my classes and you do well. But you start perceiving certain things. Is that a cockroach going? You know, is that, you know? And they have done some studies that, you know, putting a person to 24 hours of sleep deprivation, you know, and the individual has become psychotic or mimic a lot of, at least for a short period of time, a psychiatric disorder. I get a lot of bread and butter in this. My hospital is very close to, you know, certain universities, and I get patients who are practically doing well, great in their classes, not using any substance, not even to study, nothing, great kids. What happens? They get a brief psychotic episode because of lack of sleep, trying to do well in their classes, okay? And then they go back to normal. And, you know, it's something that can happen very frequent, just because of lack of sleep. And it's a public health, like I said before, you know, in all aspects, factors of suicide, etc. And in conclusion, you know, just basically, you know, the main point, you know, that you know, these are the key points, okay? Basically, everything I have talked about, but what I want you to take home is not to disregard an individual that comes to your office, can be a schizophrenic, a bipolar, have a mental illness, or not, or have comorbid medications, like I mentioned before, that has nothing to do with psychiatry, that can cause, you know, sleep disturbances. At the same time, I get a lot of calls from a good friend that I have. He's an excellent internal medicine doctor, and he calls me. He's like, hey, I'm a nurse. Can you help me out with this one? And it's the typical patient with a congestive heart failure, which we cannot use a lot of medication, and it's not sleeping at night because cannot lay back. And it's very hard to treat. But guess what? I try to help them. I try to optimize. I see it in the nursing homes when I go. Try not to use too much sedatives, but sometimes when nobody wants to use it, I use it a little bit at least, and try to mix with something else, you know, to try to put that patient to sleep, because they're going to have more shortness of breath. The exacerbation of the congestive heart failure is going to be worse if they don't sleep. Sleeping heals, and that's what I want to take home. Don't stigmatize sometimes when you see a schizophrenic on a benzo long term or a hypnotic. It's not that us psychiatrists are pill poppers. It's that sometimes these individuals need this long-term to be able to function and maintain without having a relapse. Any questions?
Yeah. Can you comment on sleep disorders and Alzheimer's? How do you treat these poor people? Because they're forgetful, they sleep during the day, they invert their sleep cycle, and are we going to help them by trying to make them sleep, or are we going to make them worse?
That's an excellent question. Sorry. That's an excellent question, and I can relate to it very well because that's usually what I do, geriatric population. Sometimes we say, oh, Alzheimer's severe, okay? Let me tell you something. 50% of patients in a nursing home are in a chronic delirium. So that severe Alzheimer's, which they are on, it's also a chronic delirium. Their cycle is shifted, okay? Sometimes, depending on what happens throughout the day, if they have a staff or caregiver that knows how to redirect well, the patient will do well. Any little minor stressor, even though they cannot remember, they felt the stressor and something in them, like a little bird, will tell them there's something wrong, and then you see that patient at night even hallucinating and not sleeping, okay? So putting them to sleep is primordial. If you cannot do it, I use little strategies. For example, if a lot of them are depressed and they have a lot of anxiety throughout the day, Remeron has some anticholinergic properties, but it's amazing on controlling anxiety and behavior right off the bat. Instead of another antipsychotic, it interacts less with a lot of medication. So we're also limited on the medications that we're going to use because they have a lot of medications on board. That's a good option because it controls pretty fast. Low dose. Start low and see where you go from there. Maybe a little bit of trazodone, start slow, half of the tab of 50, see if that helps. Okay? But you have to just try to optimize the sleep without trying to have the least cognitive impairment as possible, especially if they're on mild or moderate dementia, because the moderate has an ample road. You could have, a moderate below 20 and it's still functioning and doing a lot of things in his house, or a moderate that's almost at 10 and it's already getting into severe and can't do anything. Depends on everyone, you see. So, but even for the caregiver, okay, if this, if they don't sleep, they're going to get worse and worse. Their behavior is going to get worse and worse. So it's better sometimes, and I do it myself, hey, the temazepam is even not working, or it does. Sometimes temazepam on some individuals stop to work. You know what, let's use the 1 milligram of Ativan on an Alzheimer's patient, and you see that when they sleep, they're calmer and they do better throughout the day. Yes. Any other questions? Yes, alcoholism and sleep disturbances. So when an individual is an alcoholic, active alcoholic or binge drinker on the weekends, or recuperating alcoholic, okay, basically their cycle gets disturbed. Even on the binge drinker. And it gets to a point that even on the binge drinker, after several years, their cycle gets damaged, okay? Because, a lot of alcohol also goes into the midbrain, affecting, having atherosclerotic disease, mini stroke, stuff like that, and it's affecting the way our body regulates for sleep, right? We have structures there, And basically also, when they're withdrawing, when they're going to drink again, their cycle is totally off. There's medications that can help, okay? Doxepin has been shown to be very effective with that, okay? Trazodone has been shown in the past. Sometimes you got to be careful because of the nightmares, because if it's a binge drinker, when they binge, they had a bad night, they're going through withdrawals, the day after, sleep starts to catch up, and you get into more REM sleeps, and then you might, so you got to be careful there. And sometimes if the withdrawal is too much, you have to use the benzodiazepines, especially if the patient is committed to stop drinking, right? We use, I'm gonna give you an example. I have a patient who's schizophrenic, but it's an alcoholic. Okay, the patient was there the other day. It was admitted, some other doctors there covering, and, they did the SIGWA. They're like, oh, no, but no tachycardia, she had it yesterday, blood pressure went down, why are you gonna put in the benzo? Oh, put in benzo. Put it several times a day. Why? Well, apart from a regular alcoholic, I'm sorry, I'm going off, if I calm this patient down, because I could see her, like any of us that will have a couple of drinks one night, go overboard, and the next day we're not alcoholics, and the next day we're shaky. But then we recuperate, the next day we sleep, we're okay. On someone like that, like I was mentioning, the circadian cycle and all of that, any detrimental little change will throw these people off. So unless I want to keep the patient for 3 weeks and the insurance is only paying for 3 days, okay, then don't put benzo. Doesn't necessarily mean you're going to keep it forever, but it's going to calm the patient down. Put the patient to sleep. Use something effective. If the trazodone is not helping, at least at that time, put the Ativan, put the clonazepam, put them to sleep. Titrate it down afterwards or take it off. And in an alcoholic, if it's very chronic, be very careful. Okay, I heard a resident tell me the other day, oh no, don't worry, the patient's covered because it has a Depakote or gabapentin. There's no studies that say that if you're withdrawing from benzos or alcohol, okay, you're gonna be covered for seizures if you have an anti-epileptic drug. It has to be a benzo, or go to the local liquor store, buy a bottle of rum and put it down their throat. Because you know what? There's still a risk. It has to be that. Why? Because it's the postsynaptic receptors that they affect when the majority of antiepileptics are working on presynaptic, okay? And the excitatory compensation of glutamate versus GABA, that after a while, you using a lot of alcohol, benzos, GABA goes up. Glutamate doesn't say, oh, okay, let me stay down because GABA is up. It's going to try to compensate for that. So it's very hard for recuperating alcoholic. Why? Because it's hard for them. It is a true pathology. Then this is the bar for glutamate. Okay, once you stop the GABA. But you know what? When you stop the GABA, since you're not making it well, because you're depending on a substance, it's going to go way down. Neuronal death, I mean, even if you put a benzo, you put, some anti-epileptic drug the day after, binge drinking, you could probably prevent neuronal death because that's when apart from alcohol being toxic directly to the brain, neuronal death happens more the next day due to excitotoxicity. Calcium influx, big time, like, dementia, because of the extra glutamate it has. And it's set up here for a chronic alcoholic. So you might need benzos on these type of individuals for even a year or two, or sometimes a low dose indefinitely. Any other questions? Thank you, guys.